So hello, good morning, good afternoon and good evening to all our speakers, chairs and wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Spain, Dr. Cinta Ares. Dr. Ares is a neurosurgery attending in the Hospital Regional University de Malaga, Spain, where she performs her medical practices and also has the position of the tutor of neurosurgery residents. She also holds an active position in the neuroanatomy laboratory of the University of Malaga. After finishing her residency in 2015 from Spain, Dr. Ares worked as an attending at the famous Institute of Neurosciences in Hanover, Germany, where she specialized in skull-based procedures. She is an active researcher who has published several articles in various peer journals and also an invited faculty to various national and international conferences. We are extremely honored to have her today with us on our webinars, and today she will be talking about subtemporal and anterior petrosal approaches for petrous apex lesions. The speaker for the second session of today is our honored guest from China, Professor Enming Wang. He is a professor and vice director of Cyberknife Center at the Department of Neurosurgery at the Huashan Hospital, Fudan University, Shanghai. He is a board member of the International Stereotactic Radiosurgery Society and American Society of Clinical Oncology. He has received several awards and honors for his outstanding contribution to radiosurgery. We are extremely honored to have him today at our webinars, and today we will be talking about Cyberknife radiosurgery for malignant gliomas, recent studies and future perspectives. The chair for the first session of today is our honorable faculty from Japan, Prof. Takio Goto. Prof. Goto is the chairman and professor of neurosurgery at the Osaka Metropolitan University Graduate School of Medicine, Osaka, Japan. He is a world-renowned endoscopic skull-based surgeon and is also an invited faculty to several workshops and conferences around the world. He is a co-chairman of the Neuroendoscopy Committee of the WFNS, and we are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato, I would like to welcome both the speakers and chair for this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. And with that introduction, I would like to hand over this online podium to our first chair, Prof. Takio Koto.
Thank you. Hello, everyone. Today, I feel very honored to chair this session. The first presenter is Dr. Cinta Ares. She is an active skull-based surgeon. I'm also a skull-based surgeon, so I prefer to use the subtemporal approach or anterior or combined transpetrosal approach to resect the tumor around the petrous apex. So today I'm looking forward to listening to her lecture. So please start the lecture about subtemporal and anterior transpetrosal approach. Please start, Dr. Cinta Ares, please.
Okay, so good afternoon. Thank you so much for this kind invitation from Professor Kato and Dr. Raya, and especially to the ACNS Association. Thank you, Dr. Goto. I feel very humbled and very honored to be here today. I will be speaking about subtemporal approach and anterior petrosectomy. I will be centering in the anterior petrosectomy and its anatomical aspects and some of the most important features and tips to perform the approach. So I have no disclosures. The subtemporal and middle fossa approach has been traditionally used for the resection of small acoustic neurinomas along the internal auditory canal. So the natural extension of this approach was the anterior petrosal approach or anterior petrosectomy. This approach will involve an expanded bone resection of the petrous apex to expose the upper petroclival region and even ventrolateral brainstem. So this middle fossa approach consists in the opening of the roof of the internal auditory canal through a subtemporal route. It was initially described by House, not for the resection of acoustic neurinomas, but for intrusible vertigo, but it was the resection of these neurinomas that popularized this approach. So as we said, then natural extension of this approach was the resection of the anterior bone in the internal auditory canal. This approach was initially described as, by Professor Kawase in 1985, not for the treatment of tumor lesions, but for the clipping of aneurysms in the lower basilar artery. Some years later, its usefulness was popularized for the resection of tumors sitting on the sphenopetroclival region, such as petroclival meningiomas. So, as we all know, in the last decades, the field of skull base has evolved and developed a great variety of transpetros approaches, offering new corridors, new routes to this petroclival region, exposing this area. However, the terminology is can be a little bit confusing, sometimes probably because of the different nomenclature that has been used, but we can make two, let's say, two classifications or two types of approaches: anterior petrosal and posterior petrosal. We will talk about anterior petrosectomy, our topic today, when we are speaking about the petrous apex removal, and we will speak about posterior petrosal when we are referring to the petrous pyramid removal. Another way of dividing this classification would be that the anterior petrosal would be referring to those approaches in front of the cochlea, and posterior petrosal would be those approaches referring to the labyrinthine mass that may cover or may not cover this labyrinthine mass. So, as we said, there is a large variety of transpetros approaches, but we are looking to an approach that is giving us access to the petroclival region, Meckel's cave, and even mid-clivus and anterolateral bones. This way, it can offer us a window, a very good window between trigeminal and facial nerve, with the advantages of an extradural approach, and sometimes in certain lesions, allowing an early devascularization to the surgeon. So this will be a little summary. So we will start talking about the anatomy of the petrous apex, and then we will follow some of the steps that we follow in the operating room and discuss a little bit the applications and limitations. So referring to the anatomy of the petrous apex. So the temporal bone has 5 parts: the squamous part, mastoid part, petrous part, and tympanic part, as well as the styloid process. So the petrous part of the temporal bone has a base and an apex, which is located in the angle between the greater wing and the the greater wing of the sphenoid bone and the occipital bone here. So this petrous apex has an upper surface that is part of the floor of the middle fossa. Also has another surface, the anterior third of the posterior face of the petrous portion of the temporal bone. The petrous apex has the bony anatomy in the petrous apex has a great importance. We will go through some of the anatomical structures. Here we have the clival region, temporal and parietal bone, as well as some foramina, foramen rotundum, foramen ovale, and foramen spinosum. These 3 foramina are not actually in the temporal bone, but are very important because they contain important structures for our approach. So foramen rotundum V2, foramen ovale V3, foramen spinosum the middle meningeal artery. Here we have the petrous ridge, where we can find the superior petrosal sinus, inferior petrosal sinus, jugular foramen. Here we would find the sigmoid sinus or sigmoid sinus groove, endolymphatic duct foramina, and also internal acoustic canal. Some of the other occipital condyle foramen minor, but are not so much related with our approach today. So this is also a posterior view of temporal bone. We can see the internal acoustic meatus entering the central portion of the petrous part. Trigeminal impression would be here. Further laterally in the upper surface is the prominence of the arcuate eminence, which really overlies the superior semicircular canal. So both the trigeminal impression and the arcuate eminence are in the upper surface of the petrous part. Also, here we find the arcuate eminence a little bit more lateral, so it's superior and lateral. So also in the upper surface, we can find that the tegment is anteriorly grooved by the greater superficial petrosal nerve, extending anterior and medially. When talking about anterior petrosectomy, it's very important to remind the floor of the middle fossa. So we cannot forget to talk about it. This is a view of the middle fossa where petrous temporal bone has been drilled to expose the meatal and labyrinthine segments of the facial nerve. Also, tentorium has been removed with the exception of the tentorial edge. So the meatal and labyrinthine segments of the facial nerve are visible here, proximal to the geniculate ganglion. Middle meningeal artery is here entering the skull through the foramen spinosum, and the greater superficial petrosal nerve GSPN arising from the geniculate ganglion here, coursing anterior medially, just superior to the petrous segment of the internal carotid artery. We can see here petrosal sinus, oculomotor nerve arising from the ventral midbrain, entering the cavernosal sinus, just superior to the trochlear or ophthalmic nerves. So the tip of the petrous bone, the petrous apex, lies hidden underneath the lateral margin of the gastrian ganglion. So this is important also for our approach. The greater superficial petrosal nerve is attached to the dura mater and leaves the geniculate ganglion as it leaves the geniculate ganglion and continues into in an anteromedial direction towards the gastrian ganglion. So the proximal portion of this GSPN is usually covered in bone. But we have to take into account that in 30% of the cases, this junction of the nerve with the ganglion is not covered. So this is something that we have to take into account for our dissection and in our approach. So the internal carotid enters. This is a little reminder also of the carotid artery. The internal carotid enters the skull via periosteus canal. The esocranial opening of the carotid canal is located just in front of the jugular foramen, and the endocranial opening is near the petrous apex. So the intrapetrous carotid artery has two segments. So we have a vertical one and a horizontal one joined by the carotid knee. The horizontal segment starts at the knee and continues in the anteromedial axis of the foramen lacerum, in front of the cochlea and emerging eventually to the apex. So here there is also an image of this horizontal segment with the geno and the vertical segment. So in order to localize the petrous carotid, the posterolateral or Glasgow triangle was described, which is limited by the GSPN medially. Laterally, it would be an imaginary line extending from foramen spinosum to arcuate eminence, and the base of the triangle would be V3. So these are some of the relevant structures or steps that we have to take into account. The foramen spinosum first thing in our approach with the middle meningeal artery, foramen ovale, V3, containing V3. Once we have these two structures identified, we can start with our dural dissection, always from posterior to anterior and lateral to medial in order not to damage GSPN in the petrosal groove. We should also locate the landmark, the important landmark, the internal carotid, the Petrus horizontal portion. And then we can find our drilling limits. So the drilling boundaries will be with the shape of a rhomboid or diamond shape. We have as a lateral limit the GSPN here in black, in red the arcuate eminence, a posterior limit. Medial would be the Petrus ridge containing the superior petrosal sinus, and anterior would be the posterior border of V3 and Meckel's cave. So drilling is begun posterior and lateral to the gastric ganglion, proceeding beneath it towards the anterior and medial Petrus surface, removing bone at the floor of Meckel's cave. So depending on the size of the tumor, Petrus bone may be resected further posteriorly and medially, making it possible to open the internal auditory canal when needed. So this is a view of the exposure. Do not take into account this posterior part that it was resected with teaching purposes, but this would be a view of the anterior petrosectomy. This is a bigger image of what we could find. We could even reach the anterolateral midbrain, as we see here. So now it's time to, once we see a little bit of the anatomy, to describe a stepwise approach. Before surgery, it's important to take into account not only the relevant symptoms regarding the patient or the radiological images, or perhaps the main diagnosis of which kind of tumor we are approaching, with kind of lesion, but it's also very important to see the individual variation of pneumatization of the Petrus bone and intrapetrous neurootological structures, and very important to take into account the venous drainage pattern of the brain, as we will see later. So the patient is positioned with a 50 to 80 degrees rotation to the opposite side, so the surgeon should be positioned in front of the vertex. Intraoperative monitoring is very important for us. We rely very much on the intraoperative neurophysiology. We have a very good team of neurophysiologists with a lot of experience, and they can be very helpful sometimes in the operating room. So frontotemporal incision will be made, crossing midline with a interfacial dissection of a temporal muscle that will be reflected downwards, so it's not on our way. So this approach is made through a temporal craniotomy that extends down to the floor of the middle fossa, including zygomatic osteotomy, to get a basal exposure. Some other authors do prefer to perform an orbitozygomatic craniotomy to perhaps get a wider view, but for us, it's with osteotomy should be enough. What really the matters is to make a tailored craniotomy depending on the kind of lesion that you have to approach, and that you have a very basal craniotomy, so you can actually reach the floor of the middle fossa floor. So as general concepts that we went through before, dissection from posterior to anterior, we have to start our dissection, identifying the medial meningeal artery and B3, this medial meningeal artery and B3 complex, peeling of the trigeminal nerve afterwards, always preserving the GSPN in the petrosal groove. We should start to find on some landmarks after that, which will be the Petrus ridge, and also carotid artery and internal auditory canal. So in order to find internal auditory canal, this is sometimes a little bit of a question. So the internal auditory canal bisects the angle formed by the GSPN and the arcuate eminence. This is described in several ways. This would be the Garcia-Ibanez method. So then we recommend to identify the internal auditory canal medially and anteriorly as is safest, because medially there are not important anatomical structures. So here we have an image, a video in the OR identifying the middle meningeal artery and the V3 complex. It's always important to use, of course, sharp dissection. We are not getting so much bleeding right now, but this is a possibility. So it is important to make a small reminder, just an anatomical aspect. The petrosal artery, that is a branch of the middle meningeal artery, is partially completely covered by the bone in the majority of the middle fossa, providing some protection of the artery. But it's always important to have a careful dissection and avoid strong electrocoagulation in the area crossed by this petrosal artery that is giving blood supply to the facial nerve. So here we can see some of the dural dissection that is performed from posterior to anterior, trying to dissect the petrous ridge. That will be one of our landmarks for drilling. On the side of the petrosal sinus, here we can see a little bit of fifth nerve. So drilling should be directed behind the petrous carotid through the petrous apex, medial to the cochlea, and under the trigeminal nerve. So as a rule, once the cortical is open, the bone is relatively soft and spongy and adipose, depending on the patient's age. And in sometimes, well, an extensive pneumatization can help us with drilling. Therefore, it's good to have a previous study of the images so we can get a previous idea. So about bone removal is always one of the questions when you go to the lab and you start doing this approach. The cochlea will be, we have to remember that the cochlea is in the angle formed by the GSPN and the internal acoustic meatus posteriorly. And it will be superior, posterior, and lateral to the posterior genu of the petrous carotid. The width of the bone removal. So from the trigeminal impression to the posterior wall of the interior canal, auditory canal, literature says that it ranges from 9 to 14 millimeters. So this is some idea we can have. Of course, it varies from one patient to another. About the depth, it's described that from the trigeminal ganglion to the petroclival fissure, it can range from 9 to 17, with an average of 13 millimeter. So the petrous apex is removed until we reach the lateral aspect of the clivus, the lateral edge, until we expose the inferior petrosal sinus. This will be two of the landmarks we could take into account when drilling. Always drilling with a diamond drill. So after the bone removal is completed, the dura is cut above and parallel to the superior petrosal sinus, as we see here on the left video, just parallel to the superior petrosal sinus. Then we coagulate, and then we coagulate the superior petrosal sinus, and it will be obliterated and divided lateral to the trigeminal nerve. And then the dural incision is extended across the tentorium. I will try to. So always very careful with fifth nerve. That is there on the left. So as we said before, it's always important to have the venous anatomy into consideration. Some authors have been studying the patterns of drainage of the superior petrosal venous complex along the Petrus ridge, and wanted to see the effect on the surgical exposures obtained in the subtemporal approach. So they define a type 1 when superior petrosal complex emptied in the superior petrosal sinus above and lateral to the internal auditory canal. This was the most common type. Type 2 emptied between the lateral limit of the trigeminal nerve and the Meckel cave, at the Meckel's cave, sorry, and the medial limit of the facial nerve at the internal auditory canal. And type 3 emptied into the superior petrosal sinus above or medial to Meckel's cave. So the ideal superior petrosal venous complex for a subtemporal approach for anterior petrosectomy, it would be type 1, which luckily was the most common type. But in type 3 and those types 2 cases, the working space was significantly limited. So they proposed that normally type 3 would be the ideal type for a retrosigmoid suprameatal approach. Some other authors, this paper from Tanriovera, Roton, no, sorry, I am still in the last paper. So what they do is they propose a modified classification system and the effect that this would have on the approach. So reducing probability of venous complications we have studied. So some authors, this paper from the Professor Goto group, they study a surgical strategy, modifying the approach depending on the venous drainage. So they study the superficial middle cerebral vein drainage, and depending on it, they selected the kind of steps in the approach based on this preoperative assessment. So those sphenoparietal sinuses and cortical type venous drainage, they would perform a standard transpetrosal approach. Those patients with sphenobasal vein, they would do a limited extradural anterior petrosectomy, but combined with an intradural anterior petrosectomy. And those cases with a sphenopetrosal sinus, drainage, after standard petrosectomy, dural opening and tentorial cutting, they will stop, and after a 2-week interval do the sinus ligation. So this is just an image reminding that once we do our approach, we can find very challenging venous structures that can make our approach fairly complex and fairly difficult. So some of the applications of the anterior petrosectomy. So this approach will give us a direct access to the posterior fossa, and also to those lesions extending to the ventral brainstem anterior to the exit of cranial nerves with no traction, and allowing simultaneous access to the middle fossa and the posterior fossa. There are multiple indications we were aiming initially to speak only about Petrus apex lesions. We were centering in the anatomy, but we can see that after reviewing the anatomy that we can access also some petroclival and Meckel's cave tumors, gliomas, trigeminal schwannomas, and even some dermodyne epidermal cysts or lesions intracisternal in the posterior fossa. Some of the potential indications will be those lateral and ventral pontine intraaxial diseases, such as cavernous malformations or basilar aneurysms, as it was initially, as the approach was initially described. So some of the limitations of the approach. So I would say this approach is specifically useful in the clival region or petroclival region, but though in those lesions in the upper clivus with some extension to the middle fossa, not so useful for those middle petroclival space lesions. And when we are speaking about lower petroclival space, maybe we should think at other kinds of approaches. Some of the possible disadvantages, one of them is the epidural venous bleeding once we are doing our dissection. That can be very profuse. Sometimes venous bleeding from the posterior margin of the foramen ovale is also a matter of complexity due to the presence of bridging veins that connect the lateral cavernous sinus with the pterygoid venous plexus. I would say that those tumors whose origin is lower and posterior to the internal auditory canal are not so well resected with this approach, and those tumors originating medial to the groove of the inferior petrosal sinus, those purely clival tumors are also maybe not so good. Large tumors extending on to the lower cranial nerves or these midbrain and medulla oblongata lesions, these inferior lesions. So it has recently been reminded the efficacy of navigation systems in this kind of skull-based approaches. Intraoperative navigation is universally considered today as a helpful tool for neurosurgery in light of its accuracy. So of note, this accuracy is even greater when dealing lesions that are located in the skull base, as there is no brain shift. There is a lack of brain shift. So moreover, in the recent years, exclusive endoscopic corridors to the lateral skull base have been described to treat pathologies limited to the Petrus apex, also in other locations, petroclival region, etc. So endoscopic endonasal approaches are growing in popularity in the management of skull-based pathology. Results suggest that endoscopic transpterygoid approaches can help to achieve an optimal resection rates with limited cranial nerve palsy, especially in those tumors that are located in Meckel's cave or Meckel's cave with peripheral extension, as well as those purely, of course, in the Petrus apex. So maybe results in tumors with posterior fossa extension with some degree of neuropathy have been less than ideal, according to some authors. But due to the low incidence and anatomical variation of these tumors, it's difficult to establish the utility of endoscopic approaches, or at least there are no guidelines for the application of endonasal surgery, and these guidelines are lacking. So in conclusion, despite considerable progress in non-invasive therapeutic modalities, many lesions that involve the petroclival region and Petrus apex still require surgical treatment. This treatment remains challenging due to many characteristics. Anatomical knowledge of the petrous apex and petroclival region is of outstanding importance. An anterior petrosal approach allows both access to the middle fossa, petrous bone, petroclival region with very favorable results. Thank you very much.
Thank you, Dr. Arit. Your lecture very educative for the young doctor who want to start the Petrosal approach. Your lecture include all anatomical knowledge and also include a good point to avoid the complication such as venous drainage or something. So the audience, do you have some comment or question to this lecture? Dr. Ben, do you have a question?
Yes, and thank you so much. And this a very educational lecture, and for me, and when we are starting to gaining more experience in this approach. So I would like to ask about the difference in the exposure between the anterior petrosectomy versus the terional or even P-tempo transcavernous approach for keeping the basilar artery aneurysm. So how is the exposure in this approach versus when you go from above and drill the posterior kynoid? What additional advantage will this approach give you compared to other approach when keeping a basilar artery aneurysms?
Well, I guess if you want to do an anterior petrosectomy, you would have to do a perhaps orbitozygomatic if you want to get a wider exposure and you want to go more medially, perhaps more posteriorly. I'm not an experienced vascular surgeon, but this can give you a wider access, I think. Terional perhaps is a little bit too anterior, and perhaps it doesn't give you such a wide exposure, in my opinion. But as I said, we don't usually do vascular aneurysms we use it more for tumoral lesions, this approach.
I see. Also, may I ask, I saw in your presentation, so sometimes you will do I would say it's a limited zygomatic approach when you combine with this anterior petrosectomy. I can see that you said that this part of the zygoma. So when would that be necessary for you to remove this part of the zygoma for anterior petrosectomy?
I think depending on the location of the tumor and how much basal you need to go, we do normally remove it on a regular basis most of the times. Perhaps it's a tumor that it's more in the middle fossa and that we can reach easier. We don't have to go so medially, but we do remove it on a regular basis. Because we find it's easier to get to the base of the middle fossa. I know some authors do not do it. On the other hand, some other groups do always orbitozygomatic approach. So, I mean, it's variable. I think it should be tailored, but in most of the cases, we do remove the zygoma.
I see. Thank you so much. And it's a wonderful lecture and very educational. Thank you.
If I may ask Prof. Aris, first of all, let me thank Prof. Chinta Aris for this wonderful presentation. We learned a lot of information on various nuances of transpetrosal approaches. Thank you very much. I would like to say, do you use the lumbar drain before this procedure, because there is a lot of retraction involved with the temporal lobe, And the second question is that you do microscopic. Have you have any experience like our very honorable chair, Prof. Takikoto is a very great proponent of endoscopic transpetrosal approaches. So do you have any experience and have you compared the both?
We use, it depends on the kind of approach we are performing. We do place a lumbar drainage or we don't. Most cases we do, but if we are doing an intradural, if we are opening the dural intradural approach, sometimes we can release CSF and we do not actually need it. But I would say that in a great number of cases, we do actually use the lumbar drainage as a safety measure. Regarding endoscopic approach, we do endoscopic approaches on a regular basis. It is true that we are very comfortable with anterior petrosal approach for certain lesions, like I would say fifth nerve neurinomas. But if we are thinking of maybe a purely petrous apex lesion, cholesterol cholestatoma or something, we sometimes perform a endoscopic route. Depending on the location of the carotid, depending on how much near the sinus or how much medial the lesion is. Sometimes if it's very lateral, we will just go for an Appr approach. It is true that we have not compared our series. We have not started not so long ago to do these approaches endoscopically. So I think we have a greater experience in Appr approach than with endoscopic approach. Not so much to compare our results, and not we are still, I would say, starting to manage this kind of approaches.
Thank you very much. We have Prof. Mathuria with us. Yes, Prof. Mathuria.
This is to Dr. Ben. Actually, this approach was very well described by Professor Kawase for basilar aneurysms. So it's an excellent approach for that. But what results Professor Kawase achieved, I think the other people could not achieve the same. But it's a very small craniotomy which he used to do, and then he will do the anterior petrosectomy, and then he will approach the basilar aneurysm. It's a phenomenal approach which he has described. And because the reason is that when you are doing orbitozygomatic and all, it's an extensive approach. And here he was doing a small craniotomy, going to the anterior petrous, removing that, and then going to the aneurysms in that area. Rather, he then gathered, I had been to his library, which he has created in Tokyo. And excellent, he had the collections from all the skull-based surgeons, including Professor Hakuba and all. So, very nice. You can, it's a 10 basilar aneurysms by anterior petrosectomy approach by Professor Kawase. It's a very nice article written. Excellent.
Thank you.
It's an excellent demonstration what you have shown. Anatomy plus surgical approaches. Nice. Congratulations. Thank you very much.
There is one question in the chat box where Dr. Harshad Parekh asks, have you had any venous labae thrombosis or injury?
We haven't had any cases, but I know it's an issue. That's why I did emphasize on the study of the venous complex and the venous anatomy. It's something to take into account before the approach, because perhaps, as some of the authors report, that you want to change your approach depending on if you think it's going to be very risky. But most of the time you can approach taking into account avoiding the damage of the veins.
Thank you very much. If there are no further questions, we can invite comments from our Honorable Chair, Prof. Takikoto.
Thank you, Dr. Alex. Finally, I have just one question. In your presentation, how to seal the dural defect and bone defect? Just a fat tissue or to cover the vascularized flap? How to close the dural defect? in your
with
case?
a flap normally, with a
You
vascularized
use
flap.
a flap in all case?
Well, not always. If we have a very good dural closure, we do it. But sometimes we very like pericranium and we like it.
Okay. Thank you.
Prof. Goto can conclude the first session.
Yes. Today, I enjoyed her lecture. She presented all surgical tips how to safely perform the Petrosal approach. I like this approach. So young doctors learn this approach and distribute to this approach all over the world. Thank you, Dr. Arets. Nice lecture.
Thank you very much. We all enjoyed indeed. What a wonderful lecture it was. I'd like to mention to our viewers that this has been broadcasted on WeChat, YouTube, and Zoom. And as of now, we have around 350 people who have logged in from all over the world on all three different channels. So thank you very much, Dr. Harris, for this beautiful session, and also Prof. Koto for sharing this session. We can move on to the second session, and we can invite Prof. Wang and Min for his lecture.
Thank you for introduction. It's my pleasure to give a presentation here. So today I am my presentation is the Cyberknife radiosurgery for malignant glioma. Today I want to share our experience in the Huachen Hospital. First, I review the radiosurgery for the high-grade glioma. In 1990, leaflet reported the 6 cases of the high-grade glioma was treated by the radiosurgery. In the 1992, leaflet reported radiosurgery as the initial management for patients with malignant glioma. Key method is the patient had operation. After operation, the patient treated with 60-degree radiation therapy and plus the SIS. The median OS was 26 months. In the 1994, method report the result. The improvement in the median survival in broadly selected glioma patient treated with radiosurgery is difficult to determine. That means the radiosurgery is not benefit for some patient. You know, the RTOG 9305, the outcome was that the practicing the radiation therapy plus the radiosurgery was no significant OS benefit for GBM. But in the 1997 Counter report published the paper, the survival benefit of the stereotactic radiosurgery for patients with malignant glioblastoma. For this paper, the tumor should have the small volume. In the 2002 Novakity report, the Gamma stereotactic radiosurgery for patients with GBM, choosing the suitable patient had the survival benefit. SRC is often used as a radiation boosting for small volume recurrent and progressive tumor, in contrast to the fractionated radiation therapy. SRS rely on the highly conformal and selective delivery of the radiation based on the high definition recent brain imaging. It is delivered in 1 to 3 sessions. But you know, the Cyberknife used the 1 to 5 fraction. In the 2004, the bevacizumab Avastin antibody against the vascular endothelial growth factor, the first approved agent to target the tumor angiogenesis, has the effect on radiation damage of the brain. You know, this drug is usually for malignant tumor, but in the radiosurgery, the bevacizumab used to treat the brain edema induced by the radiotherapy. So in 2015, Redmond report SRS with the concurrent chemotherapy has shown improved local control with the acceptable toxicity in selected GBM patient. In 2020, Stanford team published a free 1-212 the 5 fraction stereotactic radiosurgery with a 5 millimeter margin with a concurrent TMZ in newly diagnosed glioma. Their outcome was that 5 fraction SIS with 5 millimeter margin with concurrent TMZ was so particularly in 5 fraction. The ARE was limited to the grade 1 and 2 and did not statistically impact the survival. That means the study is the super protocol for the GBM. Today, I want to share our patient experience, the cyber radiosurgery for the high-grade glioma. I want to show the recurrent high-grade glioma treated using the cyber radiosurgery. The second is for the initial diagnosis, the glioblastoma was treated with operation plus the fractionated radiation therapy plus the cyber radiosurgery plus the chemotherapy. In the NCCN guideline for the recurrent anaplastic glioma and glioblastoma, there is a very little method to treat this difficult disease. For the diffuse or multiple recurrence, just system chemotherapy, maybe some patient with TT field. For the local recurrent, for the resectable patient, maybe the resection, or maybe the to consider clinical trial and the TT field. But the NCCN guideline did not recommend the radiosurgery for the high-grade glioma. I want to show our appearance for the recurrent high-grade glioma treated using the Cyberknife radiosurgery. This is the GBM, 8 months post-operation, the tumor recurred. The patient required to keep speech function. We used the functional MR. The MR was merged with the localization MR. This shows the speech area in the brain, and cyber radiosurgery plus the bevacizumab and TMZ. 8 months post cyber radiosurgery, the tumor keeps stable. The brain edema not severe. But 1 year post cyber radiosurgery, the tumor recurred. And the second cyber radiosurgery and bevacizumab, for this patient, the overall survival was 24 months. This is another right parietal lobe, the GBM. The patient had operation and fractionated radiation therapy plus chemotherapy and bevacizumab and immunotherapy. 11 months post the operation, tumor recurrent. This patient required to keep the motor function. We use the DTI to show the nerve tract on the treatment planning. This is the nerve tract, and we read the lower dose for the nerve tract. So we use 5 fraction. Every fraction is the dose is 0.5 gray. The 3 months post cyber radiosurgery, the tumor recur in here, and we treat again with second Cyberknife radiosurgery. This is 6 months post the first Cyberknife radiosurgery, tumor recur, and 9 months post the CKR, the third Cyberknife radiosurgery. For this patient, the OS post cyber radiosurgery was 13 months. The patient survival the 24 months. This is a small volume of the recurrent of the GBM. We the breakthrough dose was 6 gray in every fraction, and we use 5 fraction. The 4 months post Cyberknife, we use treated the brain edema with the bevacizumab. The 8 months, the second Cyberknife, This is the 14 months post Cyberknife radiosurgery. This is the right frontal lobe of the GBM before operation. This is MR. This is the post operation. The MR showed the tumor completely removed. 1 year to 5 months, the tumor recurred here, and the Cyberknife plus the TMZ and the Petrosal 6 months, the tumor recurred. The pattern showed the little recurrence. So another operation, but the pathology do not find for cell. 6 months post the second operation, the tumor recurred here, and the second Cyberknife radiosurgery. For this patient, the overall survival was more than 5 years. For the large volume GBM, we use the two-stage Cyberknife radiosurgery. According to our experience, the recurrent GBM volume was less than 20 cubic centimeters. The Cyberknife radiosurgery had a better outcome. Two-stage Cyberknife radiosurgery for large volume recurrent GBM. The preliminary result was exciting. I showed this case. This is a recurrent the GBM after 1 year post the first operation. Then the second operation. After the second operation, the Cyberknife radiosurgery, it reaches a low precision dose combined with the Petrosal. 3 months, the second Cyberknife radiosurgery. The 10 months, the recurrent the third Cyberknife radiosurgery. The OS was 60 months post Cyberknife radiosurgery. The total OS was 27 months for this patient. This is another GBM, left side GBM. 12 months post operation, the tumor recurred. The tumor volume was the 40 cubic centimeter. Cyberknife plus the Petrosal. 3 months later, the second Cyberknife. And 7 months post the Cyberknife radiosurgery, no tumor recurred. This is 1 year post the Cyberknife, MR show no tumor. Until now, the patient has survived. And 17 months post the first Cyberknife radiosurgery. This is another recent treatment patient. Left the temporal lobe of the GBM. 10 months recurrent post operation and conventional radiation therapy. Cyberknife for this area. And 2 months later, the tumor recurred in the primary site. Second Cyberknife. 14 months post the first Cyberknife radiosurgery. The tumor recurred here, and the third Cyberknife radiosurgery. I show some of the WHO grade 3 recurrent glioma. This patient, this is before the operation, and I show the left side, the temporal, the tumor. The operation, this is after operation, the MR show the tumor right here. Pathology confirm this is the grade 3 WHO grade 3 glioma. IDH is positive. Then the patient had the GTV, the 49.4, the conventional radiation therapy, and the TMZ chemotherapy. 3 months post the operation, the tumor recurred, and the first Cyberknife, we use a lower dose. 8 months, there is the brain edema. We have suzumab for the brain edema. And 1 year, another administration of the Petrosal. And 1 year, 3 months, the tumor recurred here, and the second Cyberknife radiosurgery. And in the 2019 July, the third Cyberknife plus Petrosal. This is October 2021, MR show brain injury. This is 5 years and 2 months post operation. And this is 2023. The MR showed no tumor recurred. This is MR. So for this patient, the operation plus the fractionated radiation therapy, chemotherapy, 3-stage Cyberknife radiosurgery plus the bevacizumab, the patient has survived more than 7 years. This is another case. The WHO grade 3 high grade glioma, Cyberknife plus the bevacizumab 1 year and 2 months post Cyberknife, no tumor recur. But in November 2020, the tumor recurred, the second Cyberknife. And in the November 2021, the third Cyberknife radiosurgery plus the bevacizumab. This is 2023, the 5 years post the first Cyberknife. The MR show there are some of the brain damage. The patient had unsteady walking and speech with some difficulty. The MR show there are no tumor recur. Result can be published. The Cyberknife plus the bevacizumab for recurrent high-grade glioma. The median OS was 17.8 months post Cyberknife radiosurgery. For the WHO84, the median OS was 14.6 months. For the WHO grade 3, the median OS was 19.6 months. For the GBM, how about the operation combined with the fractionated radiation therapy plus the SIS boosting plus the chemotherapy and plus the bevacizumab? For the newly diagnosed GBM catastrophic resection, then conventional radiation therapy, 12 to 15 fraction combined with the Cyberknife radiosurgery 5 fraction and the chemotherapy. For this the treatment protocol, the shortening the radiation time and the precision SIS, reducing the brain radiation damage. With the coming of the bevacizumab, does the increasing local irradiation dose delay the GBM recurrence? So I show this patient. This patient the treatment outcome inspired me to begin our clinical study. This is the early patient. I think in the 2008. Before the operation, MR showed this is the right occipital lobe tumor. Operation and the clinical pathology confirmed this is the GBM. After operation, patient had 40 degree, the radiation therapy, and plus the Cyberknife radiosurgery, the 20 degree. This is the treatment planning. And 70 months post the operation, the tumor recurred and the second Cyberknife. And 2 years, the MR show like this. MRS showed this is the brain damage. And I recommend the patient to have the operation. The pathology confirmed this is a brain necrosis, and 3.5 years, no tumor recurred. In 5 years, I know this combined treatment method that is delay the recurrence of the GBM. So we began the clinical study for select the patient. For this patient, the 6.5 years, no tumor recur. This is a 12 year post operation radiation therapy plus the Cyberknife radiosurgery no tumor recurrence. This is provided by our Professor Dai Jiazhong. So from this case, we know the radiation therapy combined with the Cyberknife radiosurgery maybe delay the recurrence. This is a small tumor. The patient has the right side low limb numbness, and MR finds this tumor. Complete resection and his pathology confirmed this is a GBM, WHO grade 4. So after operation, we have the Cyberknife combined with the radiation therapy. 6 months after operation. This is 9 months. this is the damage of the brain. So we use bevacizumab, 18 months, 2 years, the tumor recurred, and the second Cyberknife, and 2 years and 8 months, the PET-CT indicated the tumor recurred. Then chemotherapy. 3 years and 3 months, tumor increased. Second operation. The pathology confirmed this is the GBM WHO grade 4. And we give the patient the third Cyberknife radiograph for the cavity of the tumor. For this patient, the overall survival was more than 45 months. So we began our clinical study for the GBM, phase 2 open-labeled single-arm study of the hypofractionated stereotactic radiotherapy with the chemo radiotherapy using the IMRT for the newly diagnosed glioblastoma after the surgery. Now, with the coming of the bevacizumab, does increasing the local radiation dose delay the GBM recurrence? I showed the cases. This is before the operation. This patient MR showed the tumor. This is a multiple GBM like this operation and radiation therapy for 15 fraction and then Cyberknife. And the small tumor, we give the higher radiation dose using Cyberknife. 26 months post-operation tumor recurred and metastasis in the other area within the tumor, like within the brain. The second Cyberknife, this patient has is still in follow-up. Another case, right temporal lobe, the GBM operation, and case pathology confirmed this is the GBM, and with the IDH negative, MGMT negative, Cyberknife combined with the fractionated radiation therapy plus the chemotherapy. And 2 years, 5 months, the tumor recurred, the second Cyberknife. And this is a multiple GBM operation. Histopathology confirmed this is GBM, WHO grade 4, IDH negative. We give the Cyberknife radiotherapy, 5 fraction. Then the conventional radiation therapy, 15 fraction. This is a 2 years post-operation. The follow-up MR showed there are no tumor recurred. Another patient, this is a tumor in the critical area. The tumor affects the patient motor function. So the patient, at the beginning, the patient refused to have operation. We refer the patient had the Cyberknife radiotherapy and conventional radiation therapy. After 9 months post Cyberknife radiotherapy, tumor decreased, and 22 months, 25 months, the 28 months, the tumor recurred. We refer the patient for operation. This time, the patient agreed to perform the operation. This is the MR post-operation. The tumor removed completely. But 12 months post-operation and 39 months post Cyberknife radiotherapy, the tumor recurred. And the second Cyberknife. For this patient, the overall survival was 3 years and 9 months. This is another patient before the operation. This is a tumor here. And his pathology confirmed this is the GBM. Radiation therapy combined with Cyberknife radiotherapy and chemotherapy, the 10 months. Like this, this patient, I think the 15 months, the tumor recurred and the second Cyberknife radiotherapy and combined with the bevacizumab. This is the 23 months post-operation, 40 months, the radiation injury of the brain. We give the patient the bevacizumab, and 60 months post-operation, there are some of the brain damage. The patient usually, I think maybe half a year, give the 1 or 2 times of the bevacizumab. to reduce the brain edema. So, in our hospital, we use the Cyberknife for elderly patients with GBM. Some patients do not have the biopsy. For elderly patient, the patient refuses to have an operation or biopsy. So we use staged SIS or hypofractionated SIS. The staged SIS and the hypofractionated SIS had an advantage over the fractionated radiotherapy for elderly patients with the GBM. This is our elderly patient, 77 years old, left side GBM operation, completely remove the tumor. The pathology confirmed this is the GBM, WTO grade 4, IDH negative. After operation, the patient refused to have chemotherapy and radiation therapy. 11 months post-operation, the GBM recurred. We use a two-stage Cyberknife radiosurgery. This is the first stage. This is the second stage of the Cyberknife radiosurgery. 1 year and 5 months post the Cyberknife radiosurgery, tumor decrease in size like this. But unfortunately, 1 year and 7 months, the post Cyberknife radiosurgery tumor recurred and the third Cyberknife radiosurgery. For this patient, the overall survival was 2 years and 10 months. Another old elderly patient, 75 years old. The patient refused to have operation. So we treat the patient with Cyberknife radiosurgery combined with the fractionated radiation therapy. The patient refused to have the biopsy. This is diagnosed by the MR. This is the treatment planning. The Cyberknife. After Cyberknife and fractionated radiation therapy, we give the bevacizumab for this patient. 9 months post the Cyberknife and the fractionated radiotherapy, tumor decrease. He did the 20 months post the Cyberknife radiosurgery and combined the fractionated radiation therapy. And another bevacizumab for this patient, overall survival was 27 months. This is another old elderly patient, 85 years old, male patient with the left limb paralysis. The MR found the right large tumor in the frontal and the temporal lobe, and we use a two-stage the Cyberknife. The interval between the 6 weeks, 2-3 Cyberknife. After the Cyberknife, the patient had improvement of the neurological deficit. This is the 4 months post the Cyberknife radiosurgery. This is 8 months post the Cyberknife radiosurgery. The patient survival about the 12 months because the tumor recurred. The patient refused any treatment. So our conclusion is radiosurgery for glioblastoma is coming. Over the 30 years experience with the malignant glioma radiosurgery suggests that SIS has a favorable survival benefit and is well tolerated. SIS is associated with a relatively low risk of the adverse radiosurgery effect in malignant glioma patient who has relatively lower option. Bevacizumab has shown promising results in combination with the radiosurgery. Glioma recurrence often happened at the primary site. Therefore, the local treatment with the radiosurgery was considered to be able to effectively prevent or delay the tumor recurrence. The era of the radiosurgery for GBM is coming. Fractionated radiation therapy combined with the radiosurgery boosting will delay the recurrence of the GBM. Radiation oncologists and the neurosurgeon need to change their attitude and treatment strategy for GBM. Selected suitable patient for SIS is very important. Not all patients suitable for the radiosurgery therapy. thank you for our radiotherapy team. We have the Cyberknife team and the Gamma-Knife team. Thank you for listening. Thank you all.
Well, thank you very much, Prof. Enming Wang. That was very interesting and very novel. If there are any questions from the panelists, Prof. Goto, would you like to ask something?
Thank you, Hon. Nice lecture. I understand the high dose additional the Cyberknife can control the tumor, and bevacizumab treatment can control the edema or radiation necrosis. So I understand the effectiveness to extend the overall survival of glioblastoma. So my question is, how is ADL after repeated Cyberknife? Patient cognitive function preserved or not? Or do you have some comment to the effect of ADL after repeated Cyberknife?
That is a brain edema?
He's asking about quality of life.
Yeah, I know. For the most patient, they have improved their quality of life. But for the long time, after 1 year, some patients have the lower recognition. That is to lower the some, the patient maybe have the I think the recognition for the ability or something like that 1 year later. Because I think the brain damage after the Cyberknife radiotherapy.
Okay. Thank you. So, if I may ask, first of all, let me thank you, Prof. Enming Wang, for this wonderful lecture. If I may ask, Prof, like how long? What is your protocol for surveying these patients after Cyberknife? When do you repeat your MRIs? At what stage? Is it clinical, or there is a protocol after certain months you repeat your MRI?
But in China, it's different from the Western. We usually require the patient to have MRI examination every 2 months after, post the operation. So we can find the early recurrence of the DBM. In this situation, the patient had a benefit from the radiotherapy. But sometimes the patient with the larger volume of the DBM recurrent. So in this situation, we use the 2 stages of the Cyberknife. But for this situation, the patient usually have the damage of the brain. The large volume, the large damage of the brain.
Okay, understood. Thank you. Dr. Ben?
Yeah.
Yes, and thank you so much. So I would like to ask about in China, the availability of the Cyberknife. So is it only available in a designated hospital, and also for the planning system? And usually in Hong Kong we use BrainNet, but how about in China? What kind of BrainNets? Of what kind of planning system do you use?
For Cyberknife.
Yeah.
But now I think there are about the more than 50 cyber machine has been used in around China. So in Shanghai, the cyber treatment have covered by the medical insurance. So it's very important. The medical care insurance covers this Cyberknife. So there are many patients like to have the Cyberknife when tumor recurred. But we not all the patient with the GBM is suitable for the Cyberknife. So we select some patient, the tumor not near the ventricle, ventricle, not in in the some in the brain stem. So when the tumor near or invade the ventricle, so there is some spreading through the cerebral spinal fluid. So for this situation, we usually refuse the patient for Cyberknife video surgery.
Thank you very much. Dr. Chintares, would you like to ask some?
No, I would just wanted to congratulate for this wonderful presentation. It's impressive, the number of cases. I think we don't have so much availability for Cyberknife in Spain. We do have some centers that do have access, but it's not so popularized. So it's impressive, the number of cases they have treated. So it's something to investigate on.
Thank
Dr. Raja.
Mathuria?
Yes. Say, we have experience about gamma knife in PGI, and but not in mainly in the malignant gliomas or glioblastomas. I just wanted to know that, do you think that gamma knife has got more precision as compared to Cyberknife? That is one question. The other is, when you are giving it with the fractionated radiotherapy, does it have much more radiation necrosis chances? These are the two questions.
You mean the gamma knife, compared with the Cyberknife? For the precision, I think the gamma knife is more precision than the Cyberknife. In 2007, our hospital began the Cyberknife treatment. Before, for the small volume recurrent GBM, we treated the patient with the gamma knife for small volume. I think the gamma knife for small volume tumor, Cyberknife, because they can treat the patient without the frame. We use the hypofractionation radiosurgery. We can treat some large volume of tumor.
What about radiation necrosis when it is combined with the fractionated radiotherapy? You told that 15 doses of fractionated radiotherapy and then 5 fractions of Cyberknife. Are the chances of radio necrosis more in those patients?
I think the Cyberknife maybe have the more radiation necrosis after the treatment, because the patient with the large volume, for the radiosurgery, the small volume, adverse reaction.
Okay, thank you very much. Thank you so much.
There is one question in the chat box. What is the size of tumor you consider for Cyberknife?
Yeah, what the size of tumor you consider for Cyberknife? Okay, this is a very good question. For me, I think the tumor max diameter is less than 3 centimeter is the better size. But for the usually the tumor is larger than the 3 centimeter in diameter. We sometimes treat some for some suitable patient. The result of the difference of the Cyberknife and the conventional radiotherapy, I think we cannot use the Cyberknife only for the malignant the brain tumor, especially for the glioma, the tumor do not have the clear the margin. So the conventional radiation therapy usually have the large margin, maybe 1 millimeter or to the 1.5 millimeter margin. Cyberknife, we usually use the 1 or 2 millimeter margin. So we use the combined radiation therapy and Cyberknife, not just Cyberknife for the GBM. Only for the elderly patient, only use the Cyberknife.
Thank you very much. I think if there are no further questions, we can wind this up. So I'll close this officially on behalf of the Education Committee of the ACNS and the President of Yoko Kato. I would like to thank both the speakers of today, Dr. Chinta Ares and Prof. Wang Min, for these wonderful sessions on transpetrosal approaches and radiosurgery for malignant gliomas. And very special thanks to our Honorable Chair, Prof. Takugato, for taking out his time and supporting the educational initiatives of the ACNS. A special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And as I mentioned, there are around 350 people who have logged in on different channels. And also special thanks to my co-host, Dr. Ben, who has joined us from Hong Kong despite his busy schedule. Thank you very much, Ben. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.